Well, hello, everybody. I'm Dr. Mark Morningstar, of course, your host of the Scoliosis World podcast. Thank you for tuning in for this episode. This week, I'm going to actually talk about curve flexibility, something I've alluded to on a few different episodes, but I've never really dedicated an entire episode to this topic, which I think is very important because this topic speaks to a couple of different things. First off, spinal or curve flexibility is a very important concept in scoliosis treatment, and I should say in the treatment of the curve itself, because you want to know as a clinician, for example, I would like to be able to predict right from the outset, what is my ability to provide a certain level of a result to a given patient. So for example, let's say I have a patient whose curve measurement is 25 degrees. Well, what I would like to do ideally is to be able to predict right from the outset, what is the chance that I can stabilize this curve, or what is the chance that I can improve this curve? And if I have the ability to improve this curve, what is the likely amount that I'm able to improve it by? And that tells me a few things. So first and foremost, can I even help that particular patient or not within a reasonable prediction? And B, if I can help them, how much can I help them? And I say that because the level of benefit needs to meet or exceed the level of input required on the part of the patient or the patient's family in order to get that benefit. For example, if I'm going to expect a child to go home and wear a scoliosis activity suit for a couple hours a day and sleep in a hard brace or do physical exercises that might take them an hour a day to do every day. If I'm going to expect them to do all of that and I only have the ability to improve their curve 5-6 degrees, to be quite honest, I don't know if that's worth it. Now, it might be worth it if the curve is starting out at, 18 degrees. But if I'm only going to get 6 degrees of improvement, for example, and the curve starting out is already at 45 or 50 or above, well, 6 degrees is really not a whole lot. And in that case, the patient is better off doing more extensive treatment, or even maybe at that point resort to surgical intervention if they haven't already considered that. And so curve flexibility allows me to, at least it gives me one biomechanical factor to rely upon. And there are different ways to measure that. So for example, one of the more common ways is to do it with a supine or a lying down scoliosis x-ray. And that's the way it's typically done in a child or a person who's having scoliosis surgery, because obviously they can, x-ray them right while they're on the OR table or preoperatively before they go in for the surgery to measure, when gravity is taken out of the picture, how much does that curve relax and expand. And another way to do it, because the hard part with that, of course, is, in my office and in most, clinical providers' offices, they're not going to have the ability to take a lying down x-ray in their office. I don't have that ability. And in patients who wear a nighttime Providence brace, for example, where they're sleeping in a brace and we want to send them for an in-brace x-ray, of course, you have to take that brace lying down because that's the position that they're wearing it in. I have to send them down to my local outpatient imaging center in order to obtain that x-ray measurement. But another way to assess curve flexibility is to do what we call a fulcrum side bend film. And you could do that a couple of ways. We have a very close proximity to where you can have a patient, again, lie down side lying, and this is the classical way, of course. Again, a way that you would want to do in an outpatient surgery center. But you have them do the lie on their side and with the center of their curve facing down. And what we do is we put a fulcrum bolster or some type of a block that's usually about 10 inches higher or a little bit higher. And the patient will lie on that and sort of side bend out of their curve. And that's a very reasonable way to see, okay, when the patient is laying down, how much is their curve opening up while they're side lying? And of course, you want to see that to be within a very distinct range. And that tells you a few things. First off, in cases of vertebral body tethering, for example, one of the criteria is, does that curve bend down to under 30 degrees? And if it does, then they're considered an appropriate candidate for tethering surgery. But what it does also for us is determine things like, okay, what level of improvement might be the maximal that I can expect to achieve for this particular patient if I don't do anything to increase their curve flexibility? And secondly, what is the impact, or is their spine flexible enough to suggest that wearing something like a hard brace will have the potential to lead for at least stabilization, if not improvement? And so, of course, like I have always said, in God we trust, all others bring data. And that's not my own saying. That's something I learned back in school. And even probably the person that I had learned it from probably didn't create it themselves either. So anyway, in God we trust, all others bring data. And so, of course, I have data. And as you know, I like to use more recent data, technically within the last 5 years or so, that way we're getting very recent references and the most current information. So again, this is a systematic review, and this was published in the Bone and Joint Journal. And let me see here. This is a very relatively recent one, I believe, 2022, so 3 years old. And essentially what they showed, and this is actually curve flexibility relative to bracing. And the title of this paper, and I'll have Stephen put it up on the screen. The title of this paper is Curve Type, Flexibility, Correction, and Rotation Are Predictors of Curve Progression in Patients with Adolescent Idiopathic Scoliosis Undergoing Conservative Treatment. Man, long title. And this is published out of Hong Kong. And essentially what they showed in looking at, and again, this is a systematic review, so a very, very well done, highest research, method quality. They looked at 26 total studies out of a combined 6,200 studies. And what they showed is that in patients who were wearing a brace, if that brace did not provide at least a 28% improvement, meaning the patient's curve was only 28% flexible. And all that is to say is when a patient puts a brace on, you take an in-brace x-ray, that brace should immediately improve the curve by a certain minimum threshold. Well, ideally, one of the best indicators for a brace to provide curve improvement potentially is if that brace, when you put it on and you take the x-ray, is that it immediately cuts the curve in half or more. In this case, in their review, they found that if it didn't lower the curve by at least 28%, meaning the spine's 28% or less flexible, that was significantly associated with a high degree of curve progression. So lack of curve flexibility and curve progression can be linked in a certain sense. Now, another study here, and this is published in 2023 in the Journal of Orthopedic Surgery and Research, associations between spinal flexibility and bracing outcomes, a literature review. So again, also a very strong study. And what they showed, again, looked at 1,863 articles in total. And they used 14 of them that fit the criteria and had good methodological quality. That the most prevalent method, like I alluded to earlier, was lying down x-rays or supine x-rays, was the most prevalent method for measuring spinal flexibility at the pre-bracing stage. Spinal flexibility was strongly correlated with in-brace Cobb angle corrections or correction rate. And spinal flexibility can predict bracing outcomes. So again, flexibility of the curve being the name of the game. And this I think is an important concept to understand, because obviously in both of those studies we're really talking about spinal flexibility relative to bracing. But spinal flexibility is also a very important indicator for surgical outcomes. And Obviously, the vast majority of kids who undergo scoliosis surgery have typically already tried and failed at scoliosis bracing first, or at least that's how the standard of care is supposed to be set up. Now, sometimes a child isn't diagnosed until they're already at a surgery threshold, and obviously then you're sort of bypassing the bracing stage at that point. But the ability to have good curve flexibility logically also impacts the ability to get a very fair or a very significant amount of curve correction, even from posterior fusion surgery or from vertebral body tethering. And the better flexibility they have preoperatively, the better. And I'll speak more on that in a little bit. But so again, flexibility is a very important predictor for the success of exercise programs. Curve flexibility is very important for predicting the success of bracing, as we've already heard from these studies. But then here's what's almost sort of counterintuitive, is that bracing, there's and this is an older study, but I bring it up because there hasn't really been much published on this same topic since. This is a study in the European Spine Journal, so a very prestigious journal, in 2013, so 12 years ago. And this study is, does brace treatment impact upon the flexibility and correctability of idiopathic scoliosis in adolescents? Of course, Stephen put that up on the screen as well. So this is taking it another way. This is saying, okay, we're measuring a child's spinal flexibility before they start bracing. And then we're going to measure the impact of, essentially what they did is we looked at kids who had surgery with and without prior bracing treatment. So let me make sure I'm setting this up correctly here. One group had no prior bracing treatment over at least 1 year before their spinal fusion surgery. And the second group received no prior treatment and were randomly selected from the study group's database. Curve flexibility pre-surgery and curve correctability post-surgery were calculated and compared between both groups. And they subcategorized them by curve type and location. And what they found is that both groups consisted of 35 patients, and good surgical correction, and just to read you right from their conclusions, good surgical correction it can be achieved in idiopathic scoliosis patients who have been unsuccessful with prior brace treatment. However, a history of prior brace treatment leads to a trend of lowering the curve flexibility and, in turn, negatively impacting the curve correctability. So this is interesting. So obviously, as a clinician, you have to look at this you have to look at bracing in a certain sense as kind of a double-edged sword in this regard. Because if I have a child who needs a brace by all of their metrics, they have a curve measurement that substantiates the use of a brace. If they are, either pre-menses, meaning they haven't started their first period yet, or they're prior to riser 0, riser 1, have a curve above 25 degrees, technically is SOSORT criteria. And however, the problem is some of those kids are going to do okay with bracing as long as they're compliant. Some of those kids are still going to eventually need to go on to have surgery. Well, here's the problem. If you brace a child for long enough and they still fail the bracing treatment, the problem now becomes is that they're actually going to, statistically speaking anyway, they're more likely to get less correction from the surgery than had they not done bracing treatment at all. So this poses a dilemma for people like me who are trying to find those patients who aren't going to respond. Now, to bring this all back to a back genius kind of a concept, this particular instance is exactly why we have to be able to find better ways of predicting patient or identifying patients from the outset of care as to whether or not their curve is going to respond to a conservative treatment of any type. Now, you might say, how do we do that? Well, in Back Genius, we call it the ALIGN program, ALINE, the Advanced Laboratory Integration of Genomics and Neural Hormones. And the whole purpose of that is to determine if I have a new patient in front of me, and let's say it's, 10-year-old Sally, okay? And she was just found out that she had scoliosis from her pediatrician during a well-child visit, goes to the orthopedic surgeon, and maybe the curve is 21 degrees, just as an example. What I need to do is to determine, okay, I have this 10-year-old girl with a 21-degree curve. Based on not just necessarily her age and the curve, and the curve flexibility, but also I want to find out other deeper, more intrinsic factors about Sally that might make it easier for that curve to worsen to a surgery threshold. Meaning, does she have genetic predisposition for a surgery curve? Does she have family history? Does she have any neurotransmitter issues? Does she have any hormone issues? Does she have multiple of these? Combinations of these. And if she does, then that is going to lend me into basically thinking, okay, if we calculate essentially sort of a risk of progression score or a progression factor, there is a progression factor calculated that's published by SOSORT, but it's purely a biomechanical construct, meaning age of the patient, bone maturity status, baseline measurement of the curve. The problem with that is that it doesn't take anything else intrinsically about that patient into account, because the reality is, statistically, if I line up 20 patients along a wall and they're all the exact same age and they all have the exact same curve, statistically speaking, between 10 and 15% of them are going to end up going on to require scoliosis fusion surgery or surgery of some type. Well, my job especially as a non-surgical clinician is to figure out which of those 10 to 15%, who are those people, so that I'm not treating them from the outset with a brace, for example. And now because they've done bracing, especially if they do full-time bracing recommendation, now I am hampering the potential amount of correction that the surgeon can obtain in that patient from doing the extended bracing protocol. So these are important factors to consider. And I think it behooves every practitioner to try to do their level best to find out everything they can about 10-year-old Sally to determine, is my care the most appropriate for you or not? And if it is, what does my care include? Should it include only exercise therapies at that time? Should it include bracing, but maybe it's only a part-time brace idea, like just sleeping in a hard brace, for example, and not wearing it 18 to 23 hours a day? So there are a lot of factors there that a clinician really should consider. Now, then the other nice thing becomes, let's say we take a patient who, as a sort of a final commentary on curve flexibility here, the next step of this is to say, if I have a child who is already at or above surgery threshold, but yet they don't have the curve flexibility to warrant being a really good surgical patient, meaning even though they end up going to be doing the surgery, they're going to get a less than optimal amount of curve improvement. And no matter which kind of scoliosis surgery you're doing, at the end of the day, you should, a typical scoliosis surgery should at the very least cut the curve in half. But unfortunately, there are plenty of instances where it doesn't do that. Well, if we could predict from the outset, or identify from the outset, I should say, that a specific child is looking at surgery, but their curve is not currently flexible enough, are there conservative treatment options available to help that person improve their curve flexibility so that they get a bigger benefit from the surgical intervention? And so that's one of the things. So, and maybe this particular podcast episode is a little premature, but one of the things is we literally have, as we speak right now, I have a research paper in peer review in a medical journal investigating whether or not the kinds of conservative therapies that I do here in my office, do they have the ability to improve curve flexibility to thus make that patient potentially a better surgical candidate, especially if they're already above the 50-degree surgical threshold. And I think that's important from planning purposes, especially when we're talking about newer surgeries that are very, very promising, like vertebral body tethering. Well, the one important factor, and perhaps to me, the single most important factor with the outcome of tethering surgery for scoliosis is the present level of curve flexibility. And I've had tethering doctors tell me on multiple occasions that patients who have the best curve flexibility do the best. And in fact, some tethering doctors basically use that as almost their sole criteria for determining whether or not a patient is a tethering surgery candidate. So for me, sometimes it's not about trying to treat a patient myself for getting a curve improvement for them. Sometimes it becomes, all right, I know you're going to need surgery. You're already a surgical candidate, and you're young enough to know that even if you're already at surgery threshold and you haven't even hit your main puberty growth spurt yet, this curve is going to get really bad unless we do tethering or some type of a surgery at potentially an earlier age. Well, now they can see me not from a sense of trying to improve the curve, but they can see me literally to make sure that they get the absolute best outcome they possibly can from whatever surgery they're deciding upon, maybe hopefully tethering surgery, but even fusion surgery if they don't have access to the tethering. So curve flexibility is very, very important for a number of reasons. First off, like I mentioned, it helps predict whether or not a child is going to respond to bracing. Is bracing worth doing for that child or not? Secondly, if I'm doing a surgical intervention on a particular case, does their present level of curve flexibility allow me to get an appreciable improvement in curve correction? And if it doesn't, what if we could send these patients to Morningstar or somebody similar, perhaps in the Back Genius network, where now because they've seen they've seen me or they've seen that Back Genius doctor, now they become much better candidates to have whatever surgery it is that they're seeking. And to me, at the end of the day, as long as the child gets better, that's all that matters. I don't really care who or what particular tool gets the credit. The nice thing about what I do from a Back Genius perspective is that I'm evaluating the patient and the condition we call scoliosis as a whole. Meaning I'm taking the extra steps using the align concept of identifying what hormone issues, what neurotransmitter issues, what genetic issues are going to be the most impactful or the most predictive for curve worsening, or do they have things that might, or maybe a lot of these things that we check genetically, hormonally, neurotransmitter wise are really not that big of a deal for that particular patient. So there's not much we necessarily need to do on that front. But I would much rather test a patient who is negative for those things and not have to address them than fail to test that patient from the outset, only to find out after that patient has spent months or years doing a given treatment that, quite honestly, never really had a chance to help. And now all of a sudden that family has wasted a lot of time, money, and energy into treatments that were never going to help because we could have predicted from the outset that they were likely to not help. So curve flexibility, curve flexibility, curve flexibility. Very, very important concept in scoliosis management. It's predictive, and it's also something that can be used as a clinical outcome tool, especially when surgery planning is either necessary or probably inevitable. So that's the name of the game for this week. Curve flexibility, curve flexibility, curve flexibility. Very, very, very important concept. So that's it for me for the week. Short and sweet, right to the point here. Obviously, if you like this information, please, please, please subscribe to the Scolionation's our magazine, the Scoliosis World Podcast. And speaking of Scolionation, the first issue of Scolionation magazine will be available on the backgenius.com website starting January 2026. Look out for that first issue. It's a quarterly online magazine, absolutely free to subscribe to. You just need to register for your free account on the Scolionation's page of the backgenius.com website. So again, thank you for tuning in this week. Please subscribe if you haven't already. I would appreciate that very much. And we'll see you next time.